Bariatric surgery has been around for decades, and it is highly effective. The most commonly performed procedures are the sleeve gastrectomy and the gastric bypass.
BMI has been generally used as a more convenient measure to figure out who has excess adiposity. But BMI is not a good indicator of severity. When I'm treating patients, I use BMI to identify obesity, but the severity is then figured out based on how many comorbidities they have and what the metabolic consequence of their obesity is. There are a lot of factors that we have to consider before recommending bariatric surgery. Untreated major depression or psychosis, uncontrolled or untreated eating disorders, current drug or alcohol abuse or even smoking, severe coagulopathy, severe cardiac disease, severe liver disease. All of these, which would normally be contraindications for surgery, are a contraindication for bariatric surgery too. Some of the most common side effects that we see include acid reflux, chronic nausea and vomiting, inability to eat certain foods, weight gain or failure to lose weight with the procedure, bone loss and fractures. The incidence of vitamin and iron deficiency anemia is very high after some of the bariatric surgeries. It is important to take replacements for the vitamins and iron if necessary, but also these levels need to be checked regularly.
The other way to treat people is with medication. Currently, there are treatments that produce weight loss in the range of 5% to at most 10% of body weight. But I think things are changing with the advent of highly effective injectable and oral therapies. The history of the development of obesity treatments has been littered with medications that have caused serious complications. We were trying too hard to push on a weight-regulating mechanism when the body was compensating someplace else. So we over-treated people in some cases, but in other cases, there were toxicities that occurred from the use of these medications. It's taken a very long time to produce highly effective treatments that also are very safe.
When you have a treatment that is highly effective, but not well tolerated and not safe, they might be impacting something, but not necessarily the disease mechanism. When you have therapies that are highly effective and well tolerated, they're safe, then more likely they're impacting the disease mechanisms. This new generation of anti-obesity medications are nutrient-stimulated hormone-based therapies. These therapies mimic these hormones that are naturally released in our gut and that inform our brain about hunger, about satiety, about how much energy we are carrying. We're seeing weight reduction that we've never seen before. For example, in the SURMOUNT-1 trial, which was designed to evaluate the efficacy and safety of a novel GLP-1 receptor agonist, tirzepatide, what we saw was weight reduction on average of 22.5% with the highest dose of tirzepatide, which was 15 milligrams. An earlier trial with semaglutide, which is a GLP-1 receptor agonist, the STEP-1 trial, also demonstrated remarkable weight reduction, about 15% of their total body weight. Other parameters were looked at, specifically cardiovascular parameters such as blood pressure or cholesterol. So blood pressure reduced. In terms of the cholesterol profile, there was a marked decrease in triglycerides. So these different parameters are improving. There are, of course, certain contraindications as well as side effects to consider. The two absolute contraindications are a history of medullary thyroid cancer or multiple endocrine neoplasia type 2. Additionally, if your patient has a history of pancreatitis or gallbladder disease, specifically gallstones, those gallstones do need to be removed before the medication can be initiated. Potential side effects are mainly gastrointestinal, feeling nauseated, having diarrhea, constipation, or vomiting. Most of these side effects occur during dose escalation. The best way that you can help mitigate that is by slowing the uptitration of the medication. As with any therapy for any chronic disease, we have to continue to monitor our patients and see them back in clinic regularly.
Obesity is so prevalent in our society that we hope to see a time when more and more primary care providers are able to address obesity in their clinics. If we are able to target the right drugs for the right level of complexity for the patient, we'll be able to cover a lot more patients and help more people achieve a healthier life.
I think a shift is occurring because now not only is obesity recognized as a disease, and now hopefully we're helping to shift that landscape so that it's actually treated as a disease, but now healthcare providers have the tools to effectively treat it as a disease.